Okay, then we're going to make it even more complicated. We're going to move down the line. We're going to talk about third line setting. John, talk a little bit about the rationale for, we now have several different PI3 kinase inhibitors. Why use a PI3 kinase inhibitor in patients with follicular lymphoma?
Yeah, well, I think there's a couple things to remember. One is that the drugs have reasonably good activity in relapsed follicular lymphoma. Response rates are on the order of 50% or so. They can have remissions that can last perhaps quite durably, but in particular median durations of remission are on the order of a year or perhaps even a little less. But the idea of using these agents is in someone where you may think that more chemotherapy or standard regimens are not going to give as much benefit as you like, and you're really looking for a different mechanism of action of cell killing. And a targeted agent that's, well, it's not necessarily cytotoxic chemotherapy, might make sense. It's a different way to kill these cells, may get around a little bit of resistance that you might have seen if in fact there is such this thing as resistance in the POD24 patients as an example. And I think that rationale has scientific basis to it. I think the big problem that we have is not knowing which of these agents to use, and that's something I'm sure we'll talk about as well. But you mentioned that there's several agents, and I think what's most important to say is that this class of drugs, in my opinion, should not be forgotten in this disease. This is something that really can help patients. I have had patients on a PI3 kinase inhibitor with relapsed follicular lymphoma who have had really quite striking reversal turnaround of their disease and done extremely well for a long period of time. It's a class of drugs that we need to remember that's in our tool chest, in our back pocket.
Yeah. Now we just saw last fall the approval of duvelisib for patients with 2 prior therapies with follicular lymphoma. This was based on the Dynamo trial. The Dynamo trial was a single-arm phase 2 trial with more than 120 some patients with all low-grade lymphomas that were entered onto the study. They had to be double refractory, right? So these patients, they had to be refractory to both rituximab and chemoimmunotherapy. And so these, in this study, we saw a 47% overall response rate and substantial progression-free survival and duration response. And it was from this study that duvelisib received its label. And then the label is not exactly the patients that were on the trial. It's for 2 prior therapy patients, not just the double refractory, which is, I think, helpful in everyday practice in using this. Pierluigi, you were part of this study as well. Can you talk to us a little bit about some of the prognostic factors? I think you had a paper on a little bit on some of the immunologic factors that might predict. Is that something we can use every day in practice, or is it mostly just an interesting?
No. Unfortunately, it's so difficult. We did a retrospective evaluation of several chemokines and cytokines to stratify the patient according to the responder versus no responder. But so far, it's so difficult to apply this kind of biological evaluation in the clinical practice. Could be in the future, but we need more patients, longer follow-up to really understand if there are some biopathological factors that you can stratify the responder versus the non-responder patients.
Yeah. Now, all PI3 kinase inhibitors are not the same. We think about idelalisib being as a delta inhibitor, duvelisib as an inhibitor of both the delta and gamma isoforms. There's a notion, it may be hard to demonstrate clinically because of just the issues of difficulty of studying this, but that by inhibiting the microenvironment, we might increase the activity of duvelisib. There's some data that it helps in T-cell lymphomas as well. Have you used duvelisib, and what's your experience with Matt with this drug?
I've started to use it. I think it's an oral twice-a-day drug, so on label use. I've seen people tolerate it. I just got to get more months on the drug before you can. I think part of this class is being able to tolerate it not only for the first 3 months, but it's got to be a drug that you're expecting for if their patients are in remission to be able to take for a long period of time. I think that one of the things that's going through the class is, do you need it all the time? Do you need to inhibit PI3 kinase all the time? Whichever isoform you're inhibiting, is it good? Or is it good to give a drug holiday or intermittent dosing? And I think those are the things that are coming back around in the class.
Yeah, it's unfortunate that a lot of that just sometimes to get these drugs approved, we get some very straightforward things, but we have a lot to learn with duvelisib. We have a lot to learn with all these inhibitors. We're going to talk a little bit later about some of the newer agents, and in the question will come up just as you're saying: is it the drug that's different, or is it the schedule that it's being used in, and is that better tolerated? We know, of course, there are all these class of agents have adverse events such as immune-related events that are concerning. But this drug is different than, in terms of the isoforms it hits, than copanlisib?
Right. I think that's the unique, interesting thing about duvelisib that, does make it at least scientifically exciting, in that it also hits the gamma isoform in addition to the delta isoform. So if you remember, idelalisib is really a pure delta inhibitor. And of course, as we've said, duvelisib hits gamma as well, and that's what you've mentioned, the idea that maybe it's causing some changes in the tumor microenvironment that would be important for inhibiting cell growth or proliferation. So it's through interactions with myeloid cells or even T cells in the microenvironment. I think that data is very appealing from a scientific standpoint. From a clinical translation, I'm not sure it necessarily makes a difference yet that we've seen. But we'll know even more, though, when we start looking at the results from the T-cell studies that you alluded to. Copanlisib is a little different, and you mentioned that. That's an IV formulation of a PI3 kinase inhibitor, whereas duvelisib and idelalisib are oral agents. The copanlisib, I think, has been limited in its use and exposure in the United States simply because of that IV administration that's weekly for 3 weeks out of 4, and you're doing that essentially indefinitely. So there's a lot of trips to the clinic. That's a lot of infusion time in the treatment center, and eventually there's fatigue with that on a patient standpoint. But that's a little different drug. And maybe, in fact, that's another drug where we say, we might take a little bit of a holiday. I would say we got to learn more about all of these agents.
Yeah, the schedule of administration is very different. You're getting this intermittent scheduling, intermittent dosing, which perhaps improves the adverse event profile with copanlisib. I mean, duvelisib is a continuous oral dosing, but perhaps I know that the duvelisib investigators are looking at alternative scheduling, such as you've mentioned, with holidays, decreased dosing, induction, and things like that.
I think there's also some interesting clinical trials going on with duvelisib. I think the one that I've been watching the most is the duvelisib romidepsin study. While it's in a single center, the data has now been presented multiple times, kind of as the study kind of grows, and it's giving a very interesting toxicity profile. So, what is romidepsin doing in a kind of an epigenetic fashion that may lessen toxicities or dampen that without necessarily getting potentially some efficacy in T-cell lymphomas, but also I think there was some B-cell patients on that study.
Well, the initial hypothesis, PG, was that with idelalisib was that by hitting a specific isoform, the delta isoform, then you would not get the off-target toxicity or the toxicity associated with hitting the other isoforms. Of course, there's also another potential corollary to that, is that by only hitting the delta isoform, you're going to open yourself up to some of these immunological toxicities that were predicted in the mouse models prior to that. So in copanlisib, you're hitting both the alpha isoform and the delta isoform. Does that, and it's a different schedule, it's IV, there's a whole bunch of differences, but maybe that's the same things that we're seeing with the romidepsin type data, where these combination of drugs. Usually when you combine two drugs, you get worse toxicity. In this case, you're actually getting better toxicity when you add it to duvelisib, and perhaps it's with one of these mechanisms.
I was involved in the Cronus 1 study with copanlisib, and I totally agree with you. It's a different subunity. The subunity alpha means a different safety profile. So you can, with COP, you can reduce the the toxicity in terms of immediate toxicity like colitis, pneumonitis, transaminitis, but there is an increase of hyperglycemia and hypertension that could be more easy to manage. At the same time, the difference in terms of toxicity could be related also to the schedule, because it's intravenous, but it's day 1, 8, and 15, every 4 weeks. So it's a weekly administration. So it's a different situation when you compare with daily treatment for Idela or for duvelisib, and could be this quite important in terms of the real toxicity when you compare copper versus the other two PI3K inhibitor like duvelisib and idelalisib. Anyway, logistically it's quite difficult to use copanlisib because the most part of the patient are elderly patients. They need a caregiver to go to the clinic every week for the intravenous administration. So it's a balance. Anyway, it's a real specific toxicity related to the CBNT alpha, related to the increase of hyperglycemia and hypertension.
What do you think about the alpha isoform? We know there's data, at least in mantle cell lymphoma, that may be important in a single event in mantle cell lymphoma. I don't think we have the same data in follicular lymphoma or even in chronic lymphocytic leukemia, but your thoughts on that?
Yeah, this is very interesting. For this reason, the status few trials concerning the role, the potential combination of copanlisib plus ibrutinib in the treatment of relapsed refractory mantle cell lymphoma. So there is a good preclinical rationale to do that according to this alpha isoform to try to combine and to use this drug in the treatment of mantle cell lymphoma.